Emergency department visits for low back pain. What can we learn from the literature? In the U.S. population, the 1-month prevalence for low back pain is between 35 to 37%. 80% of individuals will have low back pain in their lifetime. In the U.S., low back pain accounts for 2.74 million visits to the emergency department annually. In a recent study, researchers attempted to follow patients at 1 week and 3 months to determine what becomes of these patients and whether there are predictors of chronicity. They published these results in 2 separate publications. The first publication deals with what happens over time. The second, which we'll discuss later, takes 5 predictors and determines whether any are good at determining who becomes chronic. The title of the first publication is 1 week and 3-month outcomes after an emergency department visit for undifferentiated musculoskeletal low back pain by Friedman et al., published in the Annals of Emergency Medicine in 2012. It's important to know where this study was conducted because that context may influence results. It was conducted at an academic health center for Albert Einstein School of Medicine in the Bronx, New York. Demographics were influenced by the context of this setting. Let's look at some of these. 63% were Hispanic or Latino, 25% were Black or African American, and only 12% were other ethnic groups. It's important to note that 42% were unemployed, and of those who were employed, 28% were employed in the service industry. Data collection was accomplished by interviewing patients in the ED and then by telephone follow-up at 1 week and 3 months after ED discharge using a scripted close-ended question data collection instrument. Follow-up was quite good, obtained on 97% of participants at 1 week and 92% at 3 months. The following data was collected: age, sex, ethnic background, educational level, employment status, and type of employment. For the low back pain, the duration, frequency of previous attacks, whether MRI was used or not, prescription of medication, and a baseline Roland-Morris score. It was determined whether there was a work-related onset or not. Depression indicators were screened with a prime MD approach of asking about sadness and loss of interest in daily activities. Also obtained were the ED attending physician's diagnosis and the result of the straight leg raise for each patient. The researchers trichotomized patients' baseline history of low back pain into chronic, defined as 30 straight days with continuous low back pain, or a history of acute exacerbations more frequently than once per week, or episodic, which were acute exacerbations more frequently than once per year but less frequently than once per week, or rarely or never, which was less frequently than once per year or no history of low back pain. Interestingly, 19% had chronic low back pain, and 59% had episodic low back pain. The straight leg raise was positive in only 16%, with a diagnosis of disc herniation made in only 5% of participants. For the follow-up evaluation, the primary outcome was functional limitation attributable to low back pain, assessed with a Roland-Morris questionnaire. Secondary outcomes included pain level and analgesic use during the 24 hours before each follow-up telephone call. At 1 week follow-up, 70% of patients reported back pain-related functional impairment. 59% reported moderate or severe low back pain, and 69% reported analgesic use within the previous 24 hours. At 3-month follow-up, 48% of patients reported functional impairment, 42% reported moderate or severe pain, and 46% reported analgesic use within the previous 24 hours. Now, let's look at the second publication related to predictors of chronicity. The title of the publication is Predicting 7-Day and 3-Month Functional Outcomes After an ED Visit for Acute Non-Traumatic Low Back Pain, again by Friedman et al., published in the American Journal of Emergency Medicine in 2012. The predictors that were measured indicated low back pain-related functional disability at baseline, radicular signs, depression, a work-related injury, or a history of chronic or recurrent low back pain before the index episode. Only 2 of the 5 hypothesized variables predicted functional disability at both time points of 1 week and 3 months. The 2 predictors were a higher baseline Rowland-Morris score and chronic low back pain. So let's check off what's important about these publication results. We know that this is a specific group of patients seen in an emergency room context, and given many were unemployed, it's likely they were also uninsured. Does this translate into patients we see? That depends on your practice. Next, we know that many had moderate to severe pain. This is likely similar to the patients we see. The results suggest several things. Low back pain does not have such a benign natural history for those who are seen in an emergency room setting. At 3 months, almost half still have significant pain and are using medication. This might then represent a missed opportunity for our healthcare system. The research question is, what would happen if these same patients either initially sought chiropractic care or were referred for chiropractic care from the emergency department? We have our bias to the conclusions of such a study, but regardless, it's an experiment worth pursuing and funding. Given 84% of total medical costs for low back pain are for chronicity and recurrence, it would be important for those involved in healthcare reform to consider chiropractic care as an alternative worth investigating.